Good evening. My name is Andrew Jones, and I am the Vice President of Sales for the US and Canada for LKC Technologies. I have the pleasure of welcoming you to tonight's webinar, Detecting Retinal Damage Before It Occurs with the RETeval Device. Before I introduce our speaker for tonight, I'd like to take you through one housekeeping item. For tonight's webinar, we will be using the question functionality of GoToWebinar. So if you have a question, open up your control panel, open up the question box, type in your question, and hit send. You'll know that your question has been submitted because it should appear in that box. And Dr. Collazo will be stopping during his presentation at several points, which will give me the opportunity to pose any questions to him. I have the pleasure of introducing Dr. Ernesto Collazo. Dr. Collazo is a graduate of New York University School of Medicine. He completed his ophthalmology research fellowship at the University of Pennsylvania and his ophthalmology residency at Hahnemann University Hospital in Philadelphia. In 1993, while at Hahnemann, he was selected as chief resident by the Department of Ophthalmology and was honored with the prestigious Resident of the Year award by the Department of Surgery. Dr. Collazo was showcased by Newsweek magazine as one of the leaders in laser eye surgery in the United States. This prestigious recognition is awarded to physicians who are internationally recognized for their commitment to excellence in ocular surgery and their leadership in the use of the most advanced technology. He has also been honored on multiple occasions with the Doctor's Choice Awards, having been selected by his fellow physicians as one of the top ophthalmologists in Puerto Rico. He has been a guest lecturer for medical and non-medical organizations in the United States, Puerto Rico, and Europe. He is a diplomat of the American Board of Ophthalmology and a fellow of the American Academy of Ophthalmology. Without further ado, I'd like to hand things off to Dr. Collazo. Thank you very much for joining us tonight, and please take it away.
Thank you, Andrew, and thank you to all my colleagues for joining us tonight. I'm going to be talking about an exciting subject, and it is this new device for retinal electrophysiology known as a RETeval device. And I'm sure the title was, most of you found the title very interesting and very enticing when it says you can detect retinal damage before it occurs. And I think you'll find out that that's exactly what this new technology can do for us. Here are my disclosures. And now, as we all know, when we look at different parts of the human eye, we can evaluate their structure or their function. Now, when it comes to structure, there are subjective ways to do it, like a retinal camera or just looking at the fundus. And there's an objective way to do it with the OCT that allows us to actually measure macular thickness, look for edema, and things like that. When it comes to function, we still have the same dichotomy. We can either look at subjective studies. The visual field has been around for a very long time, and it has served us very well, but we've all seen studies that show that for a patient, for the study to show glaucoma in a patient, the patient must have lost up to 50% of their nerve fibers before the study will conclusively show that. It is a subjective test. It's not as repeatable as we would like it to be, and it has a significant learning curve for the patient. The RETeval and ERG in general is better than all those other studies for a number of reasons. First of all, it looks at function, but it is objective. So it is more sensitive and more specific than a visual field. It is also highly repeatable, as the literature clearly shows. But more importantly, this is the only device that we can have at this point that actually shows damage before it becomes permanent. By the time I see damage with the fundus camera or an OCT or a visual field, that damage has already happened, and it is irreversible in most cases. But when I see early dysfunction with an ERG, that may very well still be reversible. And that is the game changer that we see here. So the ERG is not a new technology. It's been around since the 40s. So why haven't we used it in our clinics like we use all the other technologies that I just showed? Well, for many, many years, it was a very cumbersome study to do. You have to remember that the amount of electrical energy generated by the retina is in the range of 20 millivolts. That's very, very low, and any kind of interference from, in our case, from the muscles in the face, from the extraocular muscles, and of course the brain, which is a big organ that works using electricity also, those also surround the eye. So in order to isolate the signal coming out of the eye, we would have to use special electrodes that would touch the eye. The test would be very slow, and it would take an hour, sometimes more. And interpreting the results took even longer because you have to basically look at the waves individually. So it was relegated to being used in places where they do research or multidisciplinary centers. Luckily for us, the last 25 years, the last 50 years have brought incredible advances in computational technology and miniaturization. So nowadays, we take it for granted that we have a computer in our pocket that we can use for a number of things. Those modern smartphones actually have 100,000 times the processing power of the computers that were used by NASA to land a man on the moon 50 years ago. So it should not surprise us that an instrument as small and as easily portable as the RETeval device can have the robust computational technology needed to perform a full suite of ERGs. The instrument is very easy to use. The sensors, the electrodes, are also very, very easy to place and remove. They're completely comfortable. The patient does not feel them. And that makes the testing very, very easy. The testing actually takes, in my office, about 5 minutes for both eyes to perform a full field /ERG. So that has allowed us to integrate it into our practice flow, and it's not unusual for me to tell one of my technicians, let's go ahead and get a quick ERG on this patient so that I can get a better idea of what's going on. I have a tertiary practice here in Puerto Rico, so I get basically the most complex cases coming to me, and this has become a go-to device in many of those cases that I can't imagine practicing without anymore. It has a very simple user interface, so even though it's a robust device that can give us a lot of information, the technicians learn how to use it in under an hour, in my experience. And it is one of those tests that is so easy to perform that any technician can use it and get good results. And we all know that there are some of the machines that we use that only one technician can do them well, and that makes it even more difficult to really put it into the practice flow. That's not the case with the RETeval. Anybody can use this pretty much out of the box. It has a normative database that allows the device to compare the results and actually give you a color-coded reporting. We're all used to the traffic light, green, yellow, and red reporting that we get with the OCT and other devices, and this one, it also does that for us, making it very easy to quickly look at a report and make clinical decisions. Another very important thing about this device is that it's non-mydriatic. That's a major accomplishment. All of you, I'm sure, know that ERG testing is usually done dark adapter or light adapter, depending on what you're looking for. And with this machine, it has an infrared camera that actually measures pupil size and adjusts luminosity. That's why the reports are in Trolan. So Trolan is a unit of luminosity per unit of space. So no matter what the pupil size is, and even if it changes during the test, the machine is going to adjust so that you have a constant luminosity reaching the retina and a study that is valid and that you can use. It doesn't require fixation by the patient, which is another very important thing. With something like a pattern ERG, patient has to look at a specific spot. If they look around, that's going to give you a poor result. And the other major thing is if they have media opacities, again, with those other studies, the patient won't be able to see the pattern enough to get the stimulation that you're hoping to get. With this machine, that's not an issue. So you can actually use it for patients with dense cataracts if you want to make sure that their retina is functioning properly, and it has a significant predictive value before the surgery. As you can see from the instrument, the area of contact with the patient is very, very small. It does not touch the eye at all, so it's comfortable for the patient. The sensor strip, again, does not touch the eye, so it is comfortable. And all the technician has to do is to keep the pupil inside this big red circle, which, as you can see, is not difficult. It's a very big circle. There isn't a red fixation light, so that just makes it a little bit easier for the patient to have something to look at. They don't have to be looking at that for you to get a good result. Now, just a very quick primer on electroretinography. As you know, this is our equivalent to what cardiologists do when they do a stress test. We're stimulating the organ we want to evaluate, and we are measuring the electrical activity those cells are generating as a result of the stimulus. In this case, our study is more sophisticated, no offense to our colleagues in cardiology, because we can actually look at different parts of the retina and look at different groups of cells individually, from the photoreceptors to the bipolar cells and eventually, and also the ganglion cells. Now, when light goes into the eye, reaches the retina, and finally goes through and reaches the photoreceptors, generating a polarization that and a negative wave known as the A wave. That's really produced mostly by the photoreceptors, specifically the cones and the off bipolar cells. The impulse they generate then goes through the bipolar cells and creates the B wave, and finally it's sent to the ganglion cells, generating another negative wave known as a photopic negative response. So by looking at different parts of the wave, we are actually looking at different groups of cells within the retina. As I said, the user interface is extremely user-friendly. You basically have a little joystick that you control, and you can move through the screen and decide which test protocol you want to use. And it comes preloaded with a number of different protocols. And what I like about this is that it has two different types of protocols. It has the full ER suite of protocols that you need to do a complex test that as required by the International Society of Clinical Electrophysiologists. So you can do dark adapted, light adapted, and you can do all the tests you need to diagnose something as complex as retinitis pigmentosa. But you can also use it right out of the box to do preloaded protocols that very quickly let you know if the patient has significant diabetic retinopathy and other retinal conditions. And again, the reports are very easy to interpret. The DR protocol, the diabetic retinopathy assessment protocol, it's actually a great example of this. This is a protocol that's been created by LKC that actually looks at 4 components, including the eye with the best implicit time, the eye with the best amplitude, the eye with the worst pupillary response, and the age, and it creates a score. If that score is 23.4 or lower, that patient has a normally functioning retina. But if it's higher than 23.4, not only is there dysfunction, it's highly predictive of progression. Somebody who has a DR score that's greater than 23.4 has 11 times an increased risk of needing an ocular intervention within the next 3 years. Now you can see from this study that you're going to be able to diagnose diabetic retinopathy much earlier. And I think if you remember nothing from this lecture, this is the one slide that you need to keep in mind. We have been diagnosing diabetic retinopathy for many, many, many years in the advanced stages. What we called non-proliferative diabetic retinopathy, previously background diabetic retinopathy, was actually a retina that already has significant vascular changes. Here we classified at least at moderate, if not severe, in this slide. The truth is, mild diabetic retinopathy would not show up with any of those studies, even with an OCT and even with an OCT angiography or a fluorescein angiography. Actually, the first changes happen because of some capillary loss, and what you see is dysfunction of the photoreceptors, and the ERG will show that years before you will see vascular changes that can be diagnosed with current technology. Here's an excellent study showing that, and if you see the study, it'll tell you that numerous reports have shown that electroretinography has conclusively demonstrated that in diabetic retinopathy, neuroretinal function is compromised before the onset of identifiable vascular lesions in humans. So we've always been waiting for the vascular lesions to call it retinopathy, but that's always been wrong. Retinopathy is when the neurons are starting to have difficulty, when there's the neuronal dysfunction, and that's what the ERG is going to show you. Here's an example of a DR score protocol printout, and as you can see, it's very simple. It gives you the patient's data on the top, the study that was done, which is the EDR score, and the score, and below that it actually shows you whether it's within limits or not, and it color codes it to make it even easier to see. And as in any electrophysiologic study, they're actually, you can actually look at it in a very simple way. When you stimulate those cells, they're going to respond in a certain amount of time, and they're going to respond with a certain amount of energy. So healthy cells respond quickly with a lot of energy, and cells that aren't healthy take longer and or produce less energy. So by looking at the color codes, again, anything that's the implicit time, for example, if they're in the green, that means that they're within the 9% confidence interval of the distribution curve. So that's a normal result. And when it falls into the yellow, that's what we consider borderline, and anything in the red is outside normal limits. So a study that shows an prolonged implicit time means that those cells are under stress. When the amplitude actually goes down, those cells are actually now damaged. So again, you can diagnose it as early as cells that only have a change in implicit time, and those cells can still be salvaged. They have not been permanently damaged. Here's an example of a normal study, and again, it's within normal limits. You can see again the implicit times and the amplitudes in millivolts. They're also color coded for you. You don't have to limit yourself to just looking at the top of the screen. And here's an example of one that is outside normal limits. And again, very quickly, it shows you the score. You don't have to memorize what normal is. It'll show you right below that it's outside normal limits, and it'll color code it red. So it's hard to miss what the report is trying to tell you, and it doesn't take a long time to really look at it. You can do a deeper dive into it and actually look at the scores and look at the waveforms, so you know what you're looking at. It's not just a black box spitting out a result. So you can be as detail oriented as you want to be, because the machine is really providing all that information for you. The other test that I like a lot is the photopic negative response ERG. This test is going to show you the function of the ganglion cells. So it's a little more specific. It's a lot more specific for glaucoma, and it is again highly sensitive. So here's an example where you can see I like to use a photopic negative response at minimum, and again you're going to see the implicit time and the amplitude, and it also gives you the W ratio, which is basically gives you an idea of how easily the impulse is moving through the retinal layers. Here's an example of one with photopic negative response, shows an increased W ratio as well as a decrease in amplitude in the right eye, telling you this patient is having some problems, and it could be an early diagnostic test for glaucoma. Now, before we get into the clinical cases, if there are any questions at this point?
Yes, Dr. Collazo. I had a couple of questions. One is, when and where do you use the RETeval in your practice?
I actually use in the exam lane. At this point, I do a number of them a week. So when I'm in the OR, my technicians basically take all one of the exam lanes to do the studies. But since we realized when we started using it that it's so quick, at only 5 minutes per eye, as I said before, we're actually now doing it on a patient where I'm not really sure what's going on and I want more information, and I will just tell them, go ahead and do the test right here, right now, and they will go get the machine, bring it to the exam where the patient is. I'll go on to the next exam room, and by the time I finish the next patient, that patient has had the RETeval, and I'll go back into the room and make my decision. So you don't have, it's not like you have to make some major changes in your practice flow or your infrastructure to do this test.
All right, thank you, Dr. Collazo. Another question is, do you use it in patients who are dilated or undilated?
You can actually do both. You can dilate patients if you want to, and you can do the full set of ISCEB protocols, which includes dark adaptations for 20 minutes and then light adaptation. You can do all those things. This is a full ERG suite, but you don't need to do those. You can do it when a patient who's undilated, because the machine follows the size of the pupil and adjusts the luminosity accordingly to maintain a constant level of illumination to the retina. And that's a great question. That's a very important issue here. That's a very important breakthrough that this device has given us.
Okay, great. Thank you, Dr. Collazo.
Very good. So let's go into the clinical cases. Now, this first case is a patient who was sent to me a couple of months ago by one of my optometry colleagues. And I must say, my brother is an optometrist, and I trained at Hahnemann in Philadelphia, which is affiliated with the Pennsylvania College of Optometry. So I'm very used to working with optometrists, and I have a number of very good optometrists here who send me their patients. So when they send the patient, I know the patient's been well evaluated, and obviously I'm going to get a difficult case, because if it's easy, they diagnose it themselves. So this case was referred by one of my friends, 78-year-old female, has a family history of glaucoma, and the non-contact tonometer measures a pressure of 26 millimeters of mercury. Now, optometrists here in Puerto Rico, their license is limited, so they cannot use topical analgesics, so they have to use a non-contact tonometer. Here's the pictures my colleague took, and you can see there's a little bit of asymmetry of cupping, but nothing really to hang your hand on that you can say, okay, this is clearly glaucoma. So I get a visual field. The patient is not a very good tester. It's the first time they've had a visual field. There's multiple fixation losses, high false negative rates. But if you just look at it very quickly, it looks like, well, maybe there's a superior aqueous scotoma. That's one of the earliest scotomas you get in glaucoma. So this is really glaucoma. Well, then I get an OCT of the optic nerve. By the way, the applanation tonometer gives me a pressure of 18 millimeters of mercury in the right eye and 19 millimeters of mercury in the left. So the pressure is not high. When you look at the optic nerves here, the OCT in the right eye looks perfectly normal. And this is a good OCT. And in the left eye, there's a couple of sectors that show what may be nerve fiber layer loss. So at this point, if I had no other technology to go by, I would have said, well, I have to think this is glaucoma. There's a family history. There's some nerve fiber layer loss here. The visual field I would have to repeat. What do I do? Well, let me put the patient on drops and then repeat the studies and see where I get. And it will take you months to finally come to a definitive diagnosis, maybe even longer. But I don't have to do that. I actually can go and get an ERG. And before I go through the ERG, you have to realize that the continuum of glaucoma is so that what were normal nerve fibers start showing dysfunction first, up to 8 years before there's actually loss of neurons. So by the time a visual field shows glaucoma, as we said before, 50% of the nerve fibers have been lost. That's not early or moderate glaucoma, that's advanced glaucoma. And that's why for so many years, patients with glaucoma will go blind even with treatment, because we were diagnosing them at a very advanced stage. The OCT came out almost 2 decades ago and allowed us to make those diagnoses much earlier, up to 4 years earlier. But even the OCT is showing existing permanent damage. With the ERG, you can actually show changes that are still reversible by looking at the retinal function, specifically the function of the ganglion cells. So the study that I asked my technicians to get is a photopic negative response study. That's looking at the ganglion cell function. And when you look at it, it looks normal. And both the implicit time as well as the amplitude is normal in both eyes. And it is pretty symmetric. So again, if I was thinking the left eye, maybe it's a little more advanced on the right. Well, that's not really happening here. There is no proof that there is glaucoma at this point. And again, this will be the earliest test to show glaucoma. And this is a more specific test than the others. So in order to really show myself that I wasn't getting the wrong result, this is very early when I first got my machine. And I decided, let's use another machine. And I had for a number of years a machine that from another company that actually allows me to do a visual evoked potential. This is a pattern of a multi-contrast visual evoked potential, which is a very, very sensitive test for optic nerve dysfunction. And that study also came out completely normal. Now that study wasn't as easy to do an ERG. That study takes my technicians about 45 minutes. The patients have to sit in a special room where there's nothing electronic that's going to interfere with the device. They have to sit at a specific distance from the pattern that they're going to be looking at on the screen, and they have to be able to see that pattern as well as possible. So they have to fixate on the right spot and be fully corrected. That's a whole different ball game. To show the exact same result that I had with a 5-minute test that I did in the exam lane. So I learned very quickly that I didn't have to go and continue to do VEPs when I was trying to diagnose optic nerve atrophy from glaucoma or any other cause. And a number of studies in the literature have shown that both the photopic negative response is as good as a pattern ERG or even a VEP in detecting early glaucoma. The photopic negative response has the advantage of just not requiring clear optics or refractive correction, and it can be recorded with the RETeval machine with natural pupils. The pupils do not have to be dilated. So it has been a game changer for me. Again, this patient, I was able to write in the exam room, give my colleague the answer he wanted. Yeah, the patient does not have glaucoma. Let's follow the patient as a suspect every 6 months, and we'll repeat the ERG once a year. We'll do an optic nerve OCT also once a year, so I alternate visits every 6 months. One visit I get the OCT, and the next visit we get a visual field and an ERG together. I do those things the same day of the visit, and the patients are happy, and I have the results I want. Any questions at this point?
Yes, Dr. Collazo, this is a question, not so much relating to case number 1, kind of back to the initial session, but you mentioned that the photopic tests can be very quick, 5 minutes per test. At what time are there situations where you do a photopic test, and then you decide that you need to do one of the scotopic tests, the more detailed tests? Has that ever occurred? And maybe you can describe when you would kind of do that. And then I guess the second part of the question is when do you do the more detailed tests for, retinal dystrophies like retinitis pigmentosa, that type of thing?
Right, that's a great question. When you're looking just to examine a specific layer of the retina, then the quick photopic test or the full field flash ERG will do that for you. So if I'm looking at somebody who may have diabetic retinopathy, I'm really interested in the cone function early on. Those are the cells that have the highest metabolism and the ones that are affected early on, and the ones that I worry about the most because they equate more with vision. The same thing with the example that I just showed. If I want to look at the ganglion cell because I'm thinking glaucoma, then evaluating the ganglion cell layer is equivalent to evaluating the optic nerve, because the optic nerve is nothing but a collection of the axons that come from the ganglion cells. So it shouldn't be surprising to any of us that the ganglion cells are affected in glaucoma. Of course they are. That's where the axons come from. So if I want to look at individual layers and get a quick answer, that's what I do. And this machine allows you to do that. If you're looking for a specific inherited condition or a retinal dystrophy, then you are going to want to do the full battery of ISCEP tests with dark adaptation and light adaptation, because then you have to look at the function of multiple retinal layers and how they relate to each other, and look for patterns. So somebody with cone dystrophy is going to have a specific pattern, but you have to look at all those 6 individual waveforms that you generate in those studies. So if you're looking for major dystrophies and things like that, you're going to want to do the full test. You want to do it again with dark adaptation and everything, the way you would normally do it with a much more cumbersome device. The nice thing about this is that the device is just as simple as it is for the simpler tests.
Thank you, Dr. Collazo. There was a follow-up question. What test would you use to evaluate sickle retinopathy?
Sickle retinopathy is a peripheral disease, so you want to use tests that evaluate full retinal function. Mostly the full field ERG is going to be helpful. For that, I would rather go to something more complex, like a multifocal ERG that will show you different areas of the retina differently, because with sickle retinopathy, where you're going to have are areas of ischemia that are localized, and you want to be able to see that pattern. So if you're looking for a peripheral retinal atrophy that has specific patterns, you have to go to other machines that do that. The machine that I would use for that will be, again, a multifocal ERG. It'll give you what looks like a topography of the retina, showing you the specific areas where there's been loss of function because of prolonged ischemia, which is what you would see in sickle retinopathy.
Okay, thank you very much.
Sure. Very good. So we're going to moving on for the second case. This is a very interesting case that came to my office about a week and a half ago. It's very, very recently. And this is a patient, 60-year-old gentleman who has non-insulin dependent diabetes, and who 4 weeks before had a sudden loss of vision in his right eye, a painless loss of vision that has shown a little bit of improvement since, but very little. He complains that the lower half of the images are not visible, only the upper half. The vision in that eye is count fingers at 4 feet, and it is 20/20 in the left eye. There is a trace RAPD. It's subtle, and he has a little bit of cataract, but not a major issue. I was worried about ischemic optic neuropathy, specifically GCA, and so I sent a set rate and a CRP, and they both came back normal. A few days later, obviously, and in the meantime, I went ahead and took pictures of the fundus, and you can see that there is, if you're thinking of anterior ischemic optic neuropathy, you usually see a swollen pale nerve. Well, that's not what you see here. You may have a little bit of swelling in the upper part of the right optic nerve, but I would have to convince myself of that. It's not really obvious there. The retinal looks healthy and the optic nerve looks healthy in both eyes. So what's going on here? This isn't subtle loss of vision. This is a guy who's count fingers. So I get a retinal OCT, and to confuse things more, you can see on the right macula there is a little bit of atrophy in the area of the RPE and the photoreceptors right in the center of the macula, right around the fovea. So is that causing the problems? Well, the patient has an APD. It was a sudden loss of vision. I'm not really sure what's going on. This is just making it a little more difficult, actually, to diagnose. So we get an optic nerve OCT, and you can see from the optic nerve OCT on the right that there is maybe a little bit of swelling of one of the sectors in the right optic nerve, the one that's white. Very, very subtle, but maybe that's there. There's no loss of nerve fibers, and there's no generalized swelling of the optic nerve. But when you look at the ganglion cell complex report, he does have some GCC loss. So that goes along with the RAPD and with the sudden loss of vision. So then I do a study to look at the function of both the retinal cells. So I'm looking at the photoreceptors as well as the ganglion cells. So first we look at the photoreceptors, and you can see the report on the left, and they're actually functioning just fine. Both the right and left eye have excellent implicit times and amplitudes. So those changes that we saw in the retina are not really significant enough to cause a count fingers vision. There may be a little bit of central distortion, but that's a 20/40, 20/60 retina, not a count fingers retina. But when you look at the study on the right side of the screen, the photopic negative response, now, even though the amplitude is technically within the normal range because it's shaded green, when you actually look at the numbers, you are going to see that it's 3.1, which is half as much as it is on the left eye. So that eye, it has lost 50% of its functional power. So that's telling me that the ganglion cells are indeed it's not just that the GCC thickness has gone down. So it's not just structural changes, there's actually functional changes. There is ganglion cell damage or optic nerve damage. And that damage is not reflected when you look at the retina or you look at the optic nerve head, but it's clearly something is happening behind in the optic nerve. So this is a patient who probably has non-arteritic ischemic optic neuropathy. I still want to make sure that there isn't a tumor or something else putting pressure on that eye. Because when I asked the patient on his second visit a little more detailed information, he told me that he had an episode where he had a sudden decrease in blood pressure and lost consciousness. And when he woke up, he noticed that his vision was partially gone in that eye. So he had an episode of hypotension, severe hypotension, that may have caused basically an ischemic infarct of the optic nerve. And that's why he has the defects that he shows in these studies. Again, a tumor would be really more of a red herring here, or a zebra, but this points me towards whatever's going on is going on in the optic nerve, and it's behind the optic nerve head, behind the globe. So that allows me to look at what I need to do. So this was very helpful right away to know what I had. This is a patient who's otherwise fairly healthy, and that's still working full time, very scared for what's going to happen to his vision. The fact that the function of the ganglion cells and the photoreceptors is within the normal range lets me tell the patient that they're probably going to recover a significant amount of vision. Only 40% of patients with ischemic optic neuropathy recovered vision significantly, but I am optimistic that he will fall within that group from what I can see here. And it is the ERG that allows me to come to that conclusion. None of the other studies will give me that information. The next case is a case that most of you are going to see at some point. This is a 72-year-old female that shows up, referred by a colleague in optometry for cataract surgery, and they indeed have clinical significant cataracts, but they also have mild epiretinal membranes. Question is, how significant are they? And that's going to affect my recommendation as to which kind of lens I'm going to use. And nowadays, in the era of premium lenses, that's an important consideration. This patient, if I can give them a multifocal lens that is going to make their quality of life better and makes it easy for them to function at distance and near, then I definitely want to do that. So we get you get an OCT, and you can see that there's a little bit of distortion of the retina, but not that significant. And only one of the two cross sections in the left eye actually shows irregularity. So this isn't impressive at all as to causing significant visual problems. But when you do the ERG, you do see some loss of function of the photoreceptors, both in the right and left eye, and it's significant. You can so at that point you can decide, okay, I definitely don't want to. This is a compromised retina. I do not want to put a multifocal lens in this patient because it's contraindicated. And I know that before I do anything. You can see here the left eye, the implicit time is prolonged, much more than the right eye. So yes, this patient is going to get a monofocal lens so that we can give them the best possible quality of vision. And we saved ourselves and the patient a lot of headaches and maybe a lens exchange down the line. Are there any questions at this point?
No questions, Dr. Collazo.
Very good. So let's delve a little bit into retina. Like I said, I have a tertiary care practice. I'm a comprehensive ophthalmology, so I see a little bit of everything. I see from retina to optic nerve problems to you name it. So here's a patient who's 84-year-old female who's diagnosed with diabetes in 2006, and by 2011 had diabetic macular edema, and has had a number of treatments that you can see here. So it's obviously aggressive disease that has taken a lot of treatment to control, including laser and multiple intravitreal injections, including eventually Iluvien, because nothing else seemed to work. And this is prior to Iluvien, and you can see how the significant cystoid macular edema. This is a right eye, and here's a left. Vision is still okay, surprisingly so. So the patient finally gets Iluvien, and this is what it looks like after. So the retinas look great, they're nice and dry. The left eye, there's some atrophy, so you can see the vision only improved to 20/40, but that's still very good vision. And the right eye is actually 20/25. So everybody's happy. And from that point on, the patient is followed with yearly ERGs along with other studies. In 2018, the ERG looks great. It looks normal. You can see this is the the diabetic retinopathy assessment. And on the left, you see the one from 2018, and it is normal. It's actually 15.2, which is an excellent result. So functionally, that retina is working very, very well, thanks to all the treatment that was done. That's what I call success. Now, when you go to 2019, the numbers still look really good. So I'm sorry, let me go back for a second. And the numbers are actually pretty close to what they were before. In fact, a little better. So again, everybody's happy. So you can tell in this patient that the retina is now stable. Its function has been almost fully restored, and you can now follow these patients less often. Remember, whenever we start doing intravitreal injections on a patient, we are sentencing that patient to coming in almost every month for a number of months, and eventually every 2 to 3 months. But they're seen very often in our practices, which is onerous for them and for us. If I can identify a patient where I don't need to bring them in that often, then that's very helpful for everybody involved. And the ERG allows you to do that. This is a patient who had a great response to Iluvien and who can be followed now less often. And here's an example of the exact opposite. Here's a case of somebody who's a 39-year-old young man who has type 1 diabetic retinopathy and has had also a number of treatment in the right eye. He's had 21 anti-VEGF injections and 5 lasers, and he's had 10 anti-VEGF injections in the left eye and 3 lasers. Visual acuity has been preserved as a result of that. It's 20/20 in the right eye and 20/25 in the left. Here are his angiography before and after in the right eye. And this is in the left eye. And you can see that the macula has been dried, and so he's done really, really well. When you look at the ERG after that, it's a little high, 24.3. Again, maximum is 23.4, but it's actually not too bad. You look at the amplitude, and it's 11.2 in the right, 9.5 in the left. Again, that's the eye that has a little more damage and vision of 20/40. So vision of 20/25 rather. So there's no surprises here. And when the patient comes back the following year, the results look even better. So he's doing great. The retina is recovering, its functioning abilities, and everybody's happy. And then finally, the patient comes back in 2019, and now things are starting to change in the left eye. Now, if we go back, remember, the right eye has had 4 anti-VEGF injections in that patient, and the left eye only had 1 because it wasn't that bad. But now the left eye may be developing ischemia. There is a drop in the amplitude of the photoreceptors in the left eye. So is that what's going on? Do I need to follow the patient more often? Is there already ischemia and proliferative changes? So indeed, when you do a fluorescein angiogram to look for those and look at the periphery, there is some early NVE. So yes, this patient does have ischemia in the left eye and is starting to develop the proliferative retinopathy. I would not have seen that until the patient bled or had a more significant drop in vision. And but in this case, because of the ERG, you can tell that that's going on. And that leads you to do a retinogram, do an angiogram, and then finally go ahead and treat that patient with PRP or more Avastin injections. So clearly, having the ability to do an ERG in a case like that one every year will guide you as to whether the patient needs to be followed more often, less often, whether they're getting worse, or whether they're getting better. And this is, I know getting better is an unusual concept for us in ophthalmology because usually retinal damage and optic nerve damage is irreversible. But again, we're catching functional damage early on with this technology. So yeah, some of the patients are going to get better, and the ERG is going to show improvements in function. The patient has maintained good vision as a result of that, has had a number of injections since and laser, and of course has required a tighter schedule of follow-up appointments as a result of that, but that has allowed the patient to retain good vision. by early diagnosis to see what's coming. So in summary, this technology is a powerful tool in a general ophthalmology or specialty ophthalmology or medical optometry practice. My brother, who's an optometrist in Philadelphia, and he's a comprehensive optometrist, and he was the first one actually to get the device before I did, and he was the one who convinced me to try it. I actually was, because of the size of the device, I was not convinced that it was as good as the device that I already had. So I actually went to visit his practice to try it and ordered the device before I even left to come back to Puerto Rico. He's practiced in Philadelphia, as I said before. So yes, he loves the device. He uses it all the time, as do I. And even though we have different practices, his is a general primary care practice, but he sees a little bit of everything. And I have a tertiary care general practice. So I see the patients when they're referred for further evaluation and treatment. So for both of us, it has been a very, very helpful tool. It can be used in daily practice. You can off the cuff order the test and get it done right then and there, right in the exam room, which is, again, something new for us. And the photopic negative response test has been shown over the last few years in the literature to be highly predictive of glaucoma. So again, the same device is going to help you for retina and glaucoma, for your retina and glaucoma practice. And you are going to be able to diagnose changes before they become permanent, which again is not something that we've been able to do before. There are codes for this. This is not new technology in terms of the ERG. All the insurance companies have a code for this, and it pays fairly well. Obviously, that's going to vary from state to state, so I leave you to discuss with whoever helps you with your billing and coding. But that has not been an issue. Getting paid for this device has not been a problem for our practice, either in Philadelphia with my brother or in Puerto Rico in my case. So I want to thank you for joining us tonight. I hope that you got some good information and you take a look at the device and hopefully make you a better practitioner. Are there any questions at this point?
Yes, thank you very much, Dr. Collazo. Wonderful presentation. Very much appreciate your work on this. I did have one question. I guess I'll ask the first question, and I'll do a follow-up. So I'm not sure in your practice if you're seeing patients who are diabetics without diabetic retinopathy, but is this something that you would use on a regular basis with any diabetic patient just to kind of check and see what their retinal function is?
Yeah, actually, most of my patients who are diabetics do not have visible retinopathy. Again, because I have a tertiary care practice, over the years, I've been lucky enough to develop a reputation where now most of the, highly educated patients who are looking for, a higher level of care end up in my office. Since they used to go to the United States or annual exam somewhere in New York or Miami or Philadelphia, and now they come to me. So those patients actually take good care of themselves and they want early diagnosis, which is why they come to my practice. So I actually do this test on every single diabetic in my practice. And they appreciate it because they realize this is the one device that's going to allow my doctor to diagnose retinopathy at the very early stages when there is no damage to the vasculature that can be identified. And remember, this microvascular changes, capillary changes, don't happen just in the retina. They're happening in every organ in that patient. So the damage to the brain structures, the kidneys, and the peripheral nerves are all happening at the same time. But the only place where you can see those changes in the early reversible stages is the retina. So this test is as important as them getting a stress test every year, because it's going to allow us to tell early on when they're going in the direction of diabetic retinopathy. So what I do is I would do this test every year on every diabetic. If I see the DR protocol showing that they're getting worse, that they're starting to go over 23.4, I tell them there is some significant dysfunction here. That means that there's capillary loss. Again, in every organ in your body. I'm going to send you to the primary care doctor. And what they do is they put a patch that measures the blood glucose 24/7. We've all seen those. They've been they're getting more and more useful over the years, and they would do that for about a month and try and identify when the patients are having those peaks of blood glucose level, and then making changes in their diet and exercise to get rid of those peaks and prevent that from becoming permanent damage. So when I explain it to them that way, in fact, most of them, I see diabetics for the first time when they come in, and I do a screening OCT. And if that looks normal, I say, okay, we're going to do in 6 months, I'm going to do an ERG, and I show them what the study's going to look like. And 9 times out of 10, they say, well, can I get that today? Do I have to wait 6 months to get that test? They know how important it is right away. Intuitively, they realize, oh my God, this can actually protect every organ in my body with a very simple test that I do here, 5 minutes. So yeah, I get no pushback at all on that. I wish eventually insurance companies would cover it, because when it's done in that fashion, it is a preventative test, so the patients pay for it. But the value is so obvious that, again, I've really gotten no significant pushback from my patients. They go, terrific, that sounds great. You know, and it's an extra test I do for them. But yeah, I can't imagine not doing that in every diabetic every year. It's just simply telling the patient, I'm just going to wait till the disease is advanced and it's obvious. Nobody would want that.
Thank you, Dr. Collazo. There's another question, a different topic. Is the RETeval useful to determine the presence of toxic optic neuropathy or atypical optic neuropathy, for example, NMO, anti-MOG, etc.?
Right. Again, the photopic negative response is a good way to test the ganglion cells. So if the optic neuropathy is advanced, the ganglion cells start dying off. So yes, you will see in the photopic negative response evidence of optic neuropathy. So as a screening test for that, I would definitely rely on this device. Now, if you want to get a better evaluation of the optic nerve, then you might want to do, as I did in one of the clinical cases that I presented, a pattern VEP. And a pattern VEP, especially a multi contrast pattern VEP, it's more sensitive for optic neuropathy, especially when you want to, evaluate the optic nerve more in detail. But you will be able to pick it up with the photopic negative response, that there is ganglion cell dysfunction early on.
Thank you, Dr. Collazo. Another question is, have you used the PHNR data on your glaucoma patients to decide if lower pressure is needed?
Well, I do the test every year. So retinal function should remain stable. This is a very sensitive and a very specific test. So again, this is a functional test, but it is an objective functional test. So as any objective tests, I measure every year, and I see if I see function dropping off, then disease is advancing. There's no question about that. So again, if I see the photopic negative response dropping over time, something's going on. I think a great example is that clinical case where the patient, the younger diabetic, suddenly started having loss of function, progressive loss of function in the left eye with good vision, and then you realize, well, he's having peripheral ischemia and he's starting to develop proliferative changes. This is a predictive test. It's a highly predictive test. So absolutely, I'll do the PHNR every year on every glaucoma patient. And if it starts dropping off, if I see, the first thing you're going to see is an increase in implicit time. That shows you that they're under significant stress. If you just wait it out, those cells are going to die off, and then you'll have amplitude drop. I wouldn't wait until the amplitude has dropped. As soon as I see a prolongation of the implicit time, those cells are under stress. They're going to be dying off. I'm going to go ahead and lower that patient's pressure, and so I need to establish a new pressure that's going to be my target, and I'm going to go ahead and add a medication or go ahead with SLT or refer that patient for more invasive surgery. But yeah, no question about that. I would trust this, and I do it every day.
Excellent. Well, Thank you, Dr. Collazo. That looks like it for questions. Really appreciate the time you spent with us this evening. For all those who attended this session, please, you can reach out to myself, Andrew Jones at ajones@lkc.com if you have any questions, or if you would like to request a demonstration of the device, or you can contact your local authorized LKC distributor. We will have recordings of this available on our website if you'd like to go back and review it, or look for other forwarded to colleagues. Once again, thank you very much, Dr. Collazo, for your time and a wonderful presentation today. And I'd like to wish everybody a pleasant evening, and thanks again for joining us. Take care.
Thank you. Have a good night.
Thanks, you too.